All right. Hello, everyone, and good afternoon or good evening, maybe good morning to you, depending on where in the world you are. My name is Abua. I am a medical doctor and also a doctor of public health. I have been teaching epidemiology and principles of biostatistics for about 5 years now, and I also do some work in pharmaceutical research. It's good to have you here. And thank you for taking the time to learn. Hope to hear from you. My contacts are at the bottom right of the page, and hoping to hear from you if you have questions or if you have suggestions or if you would just like to have a discussion about research. Today, we're going to be talking about bias and study quality in research. We're going to jump right in. I'm going to take you through this set of slides. I mentioned earlier that we're going to be talking about bias, and so here's the content just for your reference. Let's jump right into study quality. When you're performing a meta-analysis, as you might know, as you might remember, if you've taken a few classes in this series, in a meta-analysis, you're looking for evidence from all the studies available that have been conducted. It's not just about the quantity of studies that you have regarding a particular health outcome. It's also about the quality of the study. And so if you have 5 very strong and well done studies, you might have better results, or you may be able to come to better conclusions than if you have 20 or 30 studies that are poorly done. Something to let you know is a question would be, how do I know that a study is very, very well done? And the answer is that over time, researchers have created standardized scales that let you know objectively or relatively objectively, quite objectively, that this study is very well done and that this study is not as well done as the other. Okay, and we're going to mention and we're going to point out a few of these standard scales as we go on. All right, but let's jump right and talk about bias. And the reason why we've jumped from talking very quickly about study quality and into bias is that when a study is not very well done, it is likely to lead to bias. And the technical definition for bias is that bias is a systematic error in a study that causes an incorrect estimate of the association between exposure and outcome. And I like this definition, but I'm not a fan of jargon. So I'm going to try to explain this definition with an example. So you're looking, for example, at an exposure, smoking, very common, and you're looking at an outcome, maybe premature mortality, or heart disease. Your exposure, smoking, you believe it leads to the outcome. And you know that in research, one of the ways we can establish causation is to determine an effect size, a relative risk, a hazard ratio, an odds ratio. Bias basically says that when you do a study that is of poor quality, you might get an incorrect estimation. And so maybe in the real world, in truth, in reality, smokers are 5 times more likely to have heart disease than non-smokers. Your results may show that it is 10, 15 times larger, or it might show that there's no association at all. That is a bias. And bias can work. There are different ways to cut a bias. You know, there are different types of biases. There are different directions the bias can move. But we're just going to talk about differential and non-differential bias. When the results that we just talked about, your RR, your HR, occurs, when your bias occurs because the mistake, the systematic error you've made is different in the exposed group or in the intervention group relative to how it is in the unexposed group or in the non-intervention group or comparator group, then you would have a bias that is differential. And some people would say that your bias is non-random. But when you have a bias that is the error is made equally across both groups, you would say that that is random or that is non-differential bias. Okay, so we've talked about what bias is. We're talking about two ways you can have bias in your studies. We're going to discuss the different types of bias. So you can see that the bias with a very, very simple definition can expand and get larger and get larger. And of course, you can have more than one bias in your study. This ties to what study quality is and why you have to be certain that your studies are of high or strong quality. Okay, so let's jump back to when we're conducting trials or when we're conducting studies. And if you're thinking about study quality, you want to start from the perspective of what would a really, really good study of high quality look like if we had all the resources, if we had all the time, and if we had all the intellectual capability and the feasibility. And we, of course, every time we come back to our good old framework, the PICO framework. So you can see here, you start with your, remember that if you remember that the P in your PICO framework is your participants. And you say, can you conduct this study in the population you really want to study? What does this mean? It means that sometimes the people for whom you want to make a decision when you conduct this study and publish the results are maybe not reachable at the moment. Perhaps you want to conduct a study on a very high risk group for a sexual transmitted disease, but you're unable to capture that particular group. You might use a proxy population, maybe a more stable population of people who are at high risk, but are not exactly that population you want. Maybe you want to, and then you also think about the I in your PICO framework is your intervention. Is it ethical? Is it feasible to administer the intervention? So like we were saying just now, if you want to see the impact of smoking on an outcome, can you offer a group of people cigarettes to smoke? And can you offer them, and even if that was not frowned upon, can you offer them cigarettes to smoke for 20, 30, 40, 50 years? Because we know that the effects of smoking varies over time. It's not as immediate in most people. And so is it physical? Is it feasible? Is it ethical? And pay a lot of attention to the ethics, because you want to be a responsible researcher. The C in PICO, we know it's the comparator R. And so we're saying, for example, if you want to look at this particular drug that we know has already worked, maybe in one population, we'll come back to ethics. Does it make sense to say we're going to withhold this drug from a new population, even though we know that it has worked? And you're getting a sense of the things that you may have to do or not do that may deviate from what the ideal trial should look like. And because of these deviations, because of these feasibility issues, because of the difficulties in doing what you would do ideally, you can see where there would be limitations to your study that might affect the study quality, and then you have the O in PICO, which is the outcome and the time and so on. And let's just talk quickly about the outcome. Sometimes you need, or sometimes you cannot get to the outcome that you really need. And so you have to choose a surrogate or a proxy outcome. In cancer, sometimes you in cancer research, I beg your pardon, sometimes you are unable to capture overall survival of patients. And so you are forced to use progression-free survival, which is the point at which you can say, this patient, how long does this patient do before their disease progresses? And you use that as a proxy for something like how long does it take before the patient dies, or before the patient, we lose the patient. Okay, so and just to reiterate all I've said in that slide is, you can see how bias can creep into your study, or into a study, as a result of all these things that may be feasible, may not be feasible, and so on and so forth. Okay, so here's a table, and you can keep this and file this away as things I will always refer to, and it just gives you the different types of biases that there are. I had a professor, my advisor at some point, tell me that someone had done a count and had concluded that there are about 297 different biases identified in the literature. And I was like, wow. And she says to me, well, don't worry about it. All of those biases can be recategorized into 3 or 4 types of bias, and which is more manageable for me to have learned as a student. And of course, that was great. So you can see here that there is, how many do we have here? About 6. We have differential information bias, non-differential misclassification, confounding, bias due to missing data, and so on. Let's talk about a few of them as we go on. Okay, so let's talk about bias that can happen as a result of participant selection. Okay, so not a very what's the word to use? Not a very exciting name. Bias that can happen as a result of participant selection is called selection bias. Okay, but here's a really good example that I like, and it's very strange that these examples are passed, from one advisor to one student, and to another student, and to another advisor. So you probably have seen this before if you and I share mutual advisors. But imagine that you're a researcher, and you're excited to tell your friend or your clinical collaborator that you want to capture the impact of baldness on heart attacks. And someone might say, wait, baldness on heart attack? And yes, it's because people with male pattern baldness tend to have a higher level of androgens, which could lead to cardiovascular outcomes. And so it's not as far-fetched as it might seem when you first see this. But imagine that you tell your collaborator, and your collaborator is a cardiothoracic surgeon, and he walks into his hospital ward, and he says, I am going to enroll every bald patient I see on this ward who is admitted for a heart attack. At first glance, you're like, well, okay, maybe that's fine. Thank you very much. But when you think about it, what your collaborator or what your friend has done is he has gone into the ward and he has selected people into the study who have the exposure and who at the same time have the outcome. So he's kind of he's self-confirming your research hypothesis. And so that creates what you call a selection bias. There's a bias in the selection. And how does this bias work? It is that he has disproportionately included people with the exposure and the outcome into the study. And so what will happen is that your study will have very, very fantastic confirmatory results. So remember when I said sometimes when you have a bias, if the real value is 5 times, your results could show 10 times, 15 times, 7 times, but that is not the truth. So you would confirm a research hypothesis when that is not true. And if anyone could pop out from the screen and say, oh, I know what that is a type 1 error, you would be right. Give yourself a round of applause for getting that. Okay, let's move to the next bias. And this is loss to follow-up. Okay, loss to follow-up. Loss to follow-up is a very, very interesting concept, and I don't think it is given all the time, because loss to follow-up can actually lead to a kind of selection bias. It's very interesting, but let me try to stick to what we should be discussing today. So for loss to follow up, you could have patients who have to drop out from the study voluntarily, or people who experience some really adverse event, and then they just have to leave the study. In some cases, they break the protocol, and then they just have to leave the study. And the question is, how would this affect how would this create a bias? How would this cause a problem for your study? And so I will tell you that with another example. So think about this. If you had a drug that worked, but you don't know that this drug works, and that's why you are researching it. If you know that a drug should work, you should not further research on people. We've talked about that earlier. But this drug works very, very well, but you don't know. Now, you get people and then you randomize them. You get 100 people and you randomize them. 50 random people will get the drug. 50 random people will not get the drug. What will happen is that as the people who get the drug get better on the drug, they will continue to show up and receive the dosages of the drug. As the people who do not get better, especially if they're taking a placebo, get worse, they will leave your trial and go and try to get better somewhere else. So you can see that these people are getting better and better. These people and either the very sick ones are leaving, the very sick ones are leaving your study, and the ones who are not very sick stay in your study. And so when you calculate your relative risk, you will see that your relative risk, even though the drug really works, your relative risk would reduce, because you're going to be comparing people who have become very well with a healthier population. So you can see how loss to follow-up may affect your results. But let's talk about when it is voluntary. When people decide that, oh, I cannot come to the clinic anymore because I now live in a new city, or you did not explain very well to me that I would have to give up a day of work to participate in this study. And so there are things you can do to prevent loss to follow-up, especially when it is voluntary. One is, you have to be clear with the informed consent. The informed consent, as you may know, is you need to explain to patients what they will be going through. You don't spring surprises on patients. It is unethical. You also need to keep close to them. You follow up with them, you send them emails. Maybe you have a project manager or someone in the study who calls them and who's a liaison, and also maybe someone in the community who can track these people and make sure that any problems with participating in your trial or in your study can be managed, and when you do that, in fact, in some cases, I've heard or even experienced that when a person moves to a new city, the trial, the people doing the research would reach out and say, how about we pay for your train ticket to come in for this study, because we need everyone. We need to minimize our loss to follow up. And so some people say that your loss to follow up, especially when it's imbalance between two arms, if it's imbalanced in between two arms, it's very likely to cause bias of your results. And when you have greater than 30% missing, greater or equal to 30%, that's a generally agreed value. You might have bias due to loss of follow-up, even when it is a balanced 15% on both arms. Because how are you sure that those 30% who drop off are not significantly different from the population you're studying? Remember our PICO, and remember where we say that the ideal population may be very different from the population you're studying. And that's what happens when you have greater or equal to 30% of your participants dropping out from your study. Okay, let's oh, we're back to selection bias. And the reason why it looks like we jumped is because I was telling you earlier that your loss to follow-up bias can introduce some type of selection bias. Okay, and let's see. To determine whether there's selection bias, let's ask ourselves two questions. Number one, were participants selected into the study based on characteristics observed after the start of the intervention? So we talked about that. Did you pull people into the study because you had observed some certain characteristics about them and a likelihood of the outcome? And also, even after you've started your trial, are you analyzing the data based on a I don't want to say bias selection, because that explains, I'm explaining bias using bias, but are you selecting patients or people into your study who were adherent maybe to your intervention, or who show a greater effect of your intervention? Are those the people whose data you are identifying? And the second question would be, was the criteria for selection related to either the exposure or the intervention or the outcome? It's very similar. Maybe you would say the same thing as what we've been discussing so far. But lastly, what do you do if you have selection bias? And there are two things you can do. And number one is, in a multivariable analysis, it's best not to have selection bias, by the way, but in a multivariable analysis, you can control or you can adjust for that variable that may predict the selection of patients either into your sample or into your analysis. There's also a more advanced technique used in multivariable analysis or used in statistical analysis called inverse probability weighting. We won't talk a lot about that, or we won't even talk about it at all for this session. And maybe you can check and find resources that explain this very beautiful method that's used very widely across epidemiological and biostatistical research. Okay, so let's talk about bias in exposure assessment and outcome ascertainment. These are really fantastic looking words: exposure assessment, outcome ascertainment. As we move forward, we'll be able to unravel what these poetic sounding words really mean. Okay, so let's talk about information bias. I really like information bias. I think that it gave me pleasure to be able to memorize what it meant or understand what it meant. And so every time I see information bias, I tend to become happy. Did I hear someone say nerd? Okay. All right. So what is a recall bias? And basically a recall bias is that people would tend to recall different things, would tend to recall events with different levels of adherence to the truth, not because they're trying to lie, but just, just as a result. But here's the thing with recall bias. If I asked you, how many times did you eat a piece of meat or piece of fish or bacon in the past 2 months? You may not, you may give me an estimate, but you may not be able to tell me. And that's where you start thinking about recall bias. But there's also another element of recall bias that is worth noting. And it is that when people have an outcome, they tend to remember things more than either they should or more than people who do not have the outcome, whether those things happen to them or not. So I have this example here where someone with glaucoma will tend to remember that they were always staring at the TV screen or at their phone as a child. And then if the researcher says, how much screen time did you spend as a child? The people with glaucoma, because their brains want to tie that exposure with their outcome that they're experiencing, their brains would overestimate the amount of time they were staring at their TV screen or their phones as children. And so you can see that among the people with the outcome compared with those without the outcome, the exposure is going to be overestimated, and that is a bias. For interviewer bias, sometimes if the interviewer is, for example, very motivated to have this treatment come to market, when they ask patients questions, when they say, oh, how much did this drug improve your mood, for example, and the patient says, you know, it was just there, the interviewer might say, oh, do you mean that it did a good job? And the patient will say, well, yes, okay, it did a good job, because of the interviewer's motivation or because of the interviewer's skill or lack of skill. The interviewer might spend more time extracting positive information from some patients compared to the others. Okay, and let's talk quickly about missing data or missingness of data. It's very similar to loss due to follow-up. So I'll just read out this example here because it summarizes it perfectly, that patients who have missing data in a study, maybe they fail to show up in your study. They may fail to show up because they are sicker than the patients who stay. And so you can see that automatically missing data is predicted by a variable or by criteria that you should be considering in your study, in this case, sicker patients. Let's move to misclassification. I like this slide because misclassification bias can go 4 ways, which is why you have these 4 quadrants. Remember when we talked about random versus non-differential and non-random or differential bias. You have to, for clarity, when you're talking about misclassification biases, you have to talk about whether it's a misclassification of the outcome, a misclassification of the exposure, and you have to let yourself, not just others, but yourself know whether the misclassification is a non-random misclassification. And so you can have 4 different things and say a random misclassification of the outcome, a non-random misclassification of the outcome, a random misclassification of the exposure, a non-random misclassification of the exposure. Why is this important? It is because it's sometimes tricky for you to identify a bias. But when you are able to say it out in full, here in this instance will be an example of a random or non-differential misclassification of the outcome. When you say it out in full, you first of all, before your audience, are able to understand what it is and what the effect of this bias is likely to be. Okay, so now let's talk about what misclassification, what causes the different types of misclassification, and of course, what causes the different types of misclassification biases. And the first point here is soft instruments. Soft instruments misclassify randomly. I gave the example earlier. How many times in the past 2 months did you have meat or fish for dinner? If I gave you a questionnaire across board, everybody will get the answer, is very likely to get the answer wrongly. And so we would have a random misclassification of the exposure. I'm going to assume that what you ate for dinner is an exposure that would lead to an outcome and not an outcome. Well, it could be an outcome. Whether you eat meat or whether you eat fish for dinner could be an outcome based on your income status. But let's assume, okay, and the next thing is poorly calibrated instruments will calibrate differently. And a very good example of this is your bathroom scale. Sometimes you need to move the bathroom scale needle, if you have a manual scale, back to 0. That's called recalibration. And so think about this. If your bathroom scale is bad, or if the needle is on a 5 kilogram point every time you climb on that scale, excuse me, your bathroom scale would show that you are your real weight plus 5. If it is erratic, it will give you erratic results. And so that could lead to a differential, especially it will lead to a differential it could lead to a differential misclassification of the outcome for people who use that scale. And then when we talk about hard instruments, so the bathroom scale is a hard instrument. So there's overlap here, but we say hard instruments are less likely to misclassify. If your blood pressure is measured, especially with a very solid or standard instrument, it's unlikely to say that you do not have high blood pressure if you do have high blood pressure. And so we can say good proxies will misclassify randomly, like the dietary recall we just talked about, and bad proxies can misclassify either way. And so I'm going to ask you to tell me or to think about what are bad proxies. And maybe as we go on, I will tell you the answer to that, since there's none of you here to respond. Okay, so let's talk about bias in intervention allocation. Okay, so now why is a clinical trial, a randomized trial, a gold standard? You've probably heard that. You've probably answered questions to say, what is the gold standard? It's a randomized controlled trial. Well, the reason why it's a randomized controlled trial is that when you randomly, first of all, when you recruit randomly from a population, and then you divide randomly, or you randomize those participants, what happens is that both populations are equal to one another when randomization is well done and when the sample is large enough. Both or all the arms that you randomize to, a group of 2, a group of 3, they are equal to each other. And that starts to hint at the concept called exchangeability. It means a person or the group 1 can be exchanged for group 2. So you can assume that these two groups are the same. And so if these two groups are the same, if you give a drug to one group and give a placebo to the other group, then whatever changes in outcome you see in the one group versus the other, you can, with high confidence, conclude that it is as a result, excuse me, it is as a result of the intervention that you gave. And but in observational studies, you are unable to randomize, and so there are imbalances in different variables. And so because there are imbalances in these different variables, your results may be wrong. I might tell you the story about the studies that looked in the past at the impact of coffee on bladder cancer and how this imbalance in variables led to a wrong result if time permits. Okay, but let's go to blinding. And so we started talking about at different points when we talk about what bias looks like in some cases. Then we'll talk about what the solution is. And blinding is one of these solutions. Can anybody think about a situation where blinding participants, not physically injuring their eyes, of course, but blinding participants or the researchers could be a solution for a bias? Well, if you said anybody, okay. Well, so let's talk about blinding, and then I'll tell you what the answer is. So when you're running a study, many times, or ideally, you do not want either the healthcare workers giving the intervention or the patients receiving the intervention to know which intervention they're looking or they're receiving. And so one of those situations would be because you want to avoid interviewer bias. You don't want the people interviewing to know as such that if they are motivated. Also, maybe you don't want the physicians to know what intervention this patient is receiving, because sometimes outcomes are measured using the physician's judgment. They may not be as strict. And so when you blind just the patients, it's called a single blind. When you blind the patient and the physician, it is called double blinded. When you blind in the cases where you may blind the doctor, the patient, and maybe someone conducting a test, then you have triple blind. And this is the example here. And we're just going to move. We're just going to move on because of time. Okay. So I think that we can skip this, but we're going to talk about protocol deviations. Yes, right here. Okay, so what is the protocol deviation? I guess that we had talked about this much earlier. Remember where we said, or maybe we had started to hint at it, where we said you may not be able to capture this particular group of patients, or some patients may leave your study. And so, or some patients may be assigned to an intervention, but do not take the intervention. Think about this very quickly. If you randomize some patients to receive zinc and some patients to receive a placebo, if 50% of the patients who are supposed to receive zinc do not take their medicines, then that 50%, even though they're in the intervention group, really should be in the placebo group. So you see that there is a protocol deviation, and this can happen in your study. And so what happens? And how do you take care of this? And you can take care of this by doing three things. One is called the intention to treat, which means that you would analyze your data based on the way you designed, based on the way you allocated the patient. So even if 30% of the patients in the zinc group that we're talking about in an example do not use their zinc, you would analyze their results as though they use. That is called an intention to treat. You analyze based on your intention. You can do a modified intention to treat, and it would be everyone in the trial who could reasonably be expected to experience the impact of the treatment. And we're going to talk about this when we see in the next slide, when we look at examples. And then you can do a per protocol analysis, meaning those people who followed the protocol. So if we're looking at the people only the people who took zinc will be compared to the people who were assigned to the placebo arm. Okay, so let's look at this example here, and we'll talk about the modified intention to treat. So if you are doing a drug trial and people have to take this drug every week, but some people take the drug maybe 25 weeks out of 50 weeks. Your modified intention to treat would be, I'm not going to do an intention to treat, but I would say, if these people took this drug at least 10 times, I would analyze their data as though they took the intervention completely. Okay, so we're at the end. So why don't you take some time to think about how a study that you've read in the past or study you're involved with could have a bias in their results, or bias in how the exposure was estimated, or how the outcome was estimated. And thank you so much for listening to this session today.